All right. What time is it? Tell me when it's 5 till. Well, we got a lunch today. All right, I'm gonna teach you something that's very useful. Unless you may already know it. I'll give you an option. Okay. I'm hot now. I probably messed up my curls too. Just got my hair cut yesterday.
Not too
I
bad.
had a lion logo in the middle of my forehead.
No, you're good.
Oh, thank you. All right.
You do have two lines.
Two lines right here.
Diagonal,
It's gonna. I'm gonna massage it out.
Yeah.
It's the blood flow going. Anyway, all right. So I can make you understand MAT. I think that's a good one to do because when you get your license, you gotta do a little training course to be able to prescribe Suboxone. It's kind of mandatory for full licensing because they're trying to get more prescribers that can manage the opiate crisis. So it used to be optional, but now you need to do the CMEs to understand Suboxone. I think the course, I forget how long the course is for advanced practitioners. I think it's an 8-hour course or 6-hour course for doctors or something. It might be shorter now, but I think it's a little bit longer for you guys. And in my opinion, I can turn that into a 30-minute lecture and make you understand it forever. Okay. Now, before I do that, I need to know if you already know about it. So, are y'all familiar with buprenorphine? Yeah. Are you familiar with methadone? Are you familiar with kind of the methodology of kind of administering it?
Sort of.
Okay, sort of. Okay. Do you understand why you do each thing? You understand the why?
No.
Okay, all right. And could we trade places? You can come up here and teach me.
I'm not at that point, no.
Okay. All right, so here's a learning point. If you can't teach it, you don't know it.
Sure.
Okay. I only say that because it's a great barometer to kind of see where you're actually at. Sometimes, like, you'll be doing questions, you go, oh, I got this one right. And, you're doing stuff and you're studying, and you're going, oh, yeah. Get up at a board and try to teach it to people. Then you'll know what you don't know. Because you're like, wait a minute, what is that? And then you got to look back. That means you don't know it. Okay, so here's a tip. If you're preparing for exam, preparing for stuff, get your cat. Hey, Agnes, I want to teach you about medication-assisted therapies. The cat goes, meow. If your cat can't walk away and prescribe Suboxone, you don't know it. I'm just kidding. So we can do MAT, or we can kind of do like mood disorders, because obviously that's my specialty area. Which one do y'all prefer?
I think I would prefer MAT.
Good. That's what I was hoping you were going to say. Very good. All right. What does MAT stand for?
Medication-assisted therapy.
All right. And what's the purpose? I did. Good. Very observant. What is the purpose of medication-assisted therapy? Who's it for?
Patients who need medication to assist their therapies.
Great answer. Great answer. I love it. And you said it with confidence.
Did I?
Any ideas who MAT is for?
Like substance abuse patients.
Okay, I'll give you that. Mm-hmm. So, MAT is for substance use disorders. Primarily, what I'm going to teach today is for opiate use disorders. Now, there is medication-assisted therapy for like alcoholism, because you can prescribe like naltrexone and Vivitrol and what's my other one? That's Sulfran, which is antabuse. But we're not going to go into that. We're going to just focus on opiate use disorders. All right. Now, when I ask you who's it for, this is the people. Now, remember what you're doing. We talk about that specialized knowledge before, and you talk about your audience. Even if you see patients one-on-one, you still have an audience, just like one at a time. And any business, all it does is solve a pain point for a person that they can't solve on their own, so they give you money. Oh, I'm hungry. I need something to eat now. I got to be somewhere. You won't go to a fast food place because I need food fast. You're solving my pain point, which is hunger and time restriction. Okay. So we always want to identify when any treatment that you're doing, like who is it for? I think that's important. All right. Now, what are some of the tools I use in MAT? And I said one, a Suboxone, which is buprenorphine. naltrexone. I always get it mixed up. Naltrexone, naloxone, one of the two. Y'all can look it up for me right quick. Okay. So basically, a partial agonist and a full antagonist in a combination pill. I think it's naltrexone. Whichever one I say, it's always the opposite. So look it up for me right quick. And you can just.
Naloxone.
No, I knew it. I always do it every time. That's why I said if I wrote this one, it means it's a level.
Yeah.
Naloxone. All right, I'm gonna remember that. I'm gonna start saying buprenorphine and Narcan. That's what I'm gonna start saying.
Yeah.
I'm gonna start saying it like that. All right. What are the other tools that you have for opiate use disorders on the medication-assisted therapy? You have any other ideas? I said a couple of them before. Methadone.
Yeah.
All right. I like that. What else you got? I said the other two already. Naloxone
Naloxone, yeah.
and naltrexone. This is kind of like your bread and butter things for medication-assisted therapy. Now, there are other like supportive medicines as well, but there's something that's similar across all of these meds. Now, this is an important concept since y'all have not been with me. Here's how I make sure that I can pull most things out of my mind. It's because, like I talked about before, I remember concepts, I remember narratives or stories, I remember principles. But here's one other one I didn't tell you. I remember frameworks or categories. So to me, I'm doing my best to make anything fall into some type of framework or category and trying to figure out what principle it works on. That way I can make a story out of it so I can understand the concept. Oh man, that's the first time I said it like that, but that makes perfect sense to me. I should have wrote it the other way. Okay. So when I think about MAT, the thing that's similar about all those things is those medicines interact with the opiate receptor. If you don't remember, that's a mu receptor. And those medicines fall as either agonists, they fall as antagonists, or they fall as partial agonists. Okay. Now, for you to understand MAT, you have to understand these three core concepts. Okay. So I need y'all to define those for me. What is an agonist?
They activate receptors.
Ooh, that girl cold.
I've been studying it.
I love that. All right. You don't get to answer this one. What's an antagonist?
I mean, obviously, deactivate.
All right. So this deactivates or blocks. So it blocks the activity of the receptor. All right. Here's the $1 million question. What the heck is a partial agonist?
It has some effect on receptors, but not as much as an agonist, like a full agonist.
That's almost a full answer. Almost there. Don't change anything else you already said. There's a little bit more to it. Want to help?
They work like in the environment that's around them.
That's right. So that makes them. So you said partial agonist does not have the full effect of an agonist. It can activate the receptor,
Yeah.
but not have the full effect as an agonist. But guess what? It can also block the receptor, but not have the full effect of a full antagonist. So therefore, it operates based on the environment that it's in. So you were here when I explained that last time?
Mm-hmm.
Okay. I was like, man, she has been studying her butt off.
No, I did study it.
She's
but...
in my brain. So to make that make sense, and the analogy I used last time, it's always use a light switch. Hit the light switch on, that activates that circuit, the light comes on. So basically, an agonist turns the activity receptor on. Antagonist is like popping the light switch down. It deactivates the activity of that receptor and all the kind of downstream changes that's supposed to happen in the cell. But then a partial agonist is like a dimmer. Man, it's dark in here. Let me just turn it up a little bit. That means like in the absence of full agonist or light in this analogy, a partial agonist is going to partially turn the light on. So it's going to work like an agonist. All right? And then the reverse can be true. Oh man, it's bright. Oh my God, it's bright in my retinas. And you take that dimmer, you can turn down. Like I always think about the little studio light, like when you're ready to record a YouTube video. Now that I'm a YouTube star, I turn up too bright, like like a vampire, and you just turn a little knob, and it comes down and dims the light. So a partial agonist works like that too. So in an environment where there's lots of the substrate around the cell, if I give you a partial agonist, it's going to block some of the activity of that receptor. Okay, that makes sense?
Mhm.
So that's really important to understand MAT is that our medicine is going to fall into those categories. So we have our agonists. Our full agonist is going to be like good old methadone. That's going to be my full agonist. My partial agonist is going to be buprenorphine. I can't spell it. Buprenorphine, however that spells it. I'm just scribble it like that.
Classic doctor.
Beautiful. Doctors can't spell. That's why we write like that.
You have to go to a class to like really.
That's true. That's true. That's like one of the main, like when you first get there, they teach you that.
Doctor 101.
Yep. Doctor writing 101. It's like, you don't have to remember so much vocabulary. You won't be able to spell everything. So here's how you write. All right. So these are kind of my tools in MAT when I'm dealing with substance use. So I can give you a full agonist, boom, and that's going to make the effect. So to help me understand this, I need a narrative, right? So here's my narrative. So I always think about like, what's the cost of having an opioid use disorder? And I imagine, like New Jack City. I don't know if y'all ever seen that movie. That was about the crack epidemic, how that impacted like the drug dealers in the community and stuff like that. I'm just imagining like someone who is in the throes of opiate addiction. What do? Well, they go to the doctor. They tell the doctor they're in pain, so they can get opiate pills. And one day the doctor catches on. He's like, "Wait a minute, you're addicted. I can't give you any more opiate pills." Well, guess what? Your body's addicted to it now. I need my opiate, so there's gonna be consequences and repercussions. Therefore, now I got to do something to get these drugs. Okay, I don't know, maybe I'll break my finger on purpose so I can get opiates. Oh, they still didn't prescribe it to me. They gave me freaking Tylenol. What the hell? Okay, what am I going to do now? Oh, Granny might have some, so I might steal. Oh, Granny didn't have any. All right, let me go start hanging out in some shicey places. Hey, man, I can get some smack, man. All right, you start sharing needles, or you start prostituting, or you rob somebody, or you know what I'm saying? It's just a spiral. So the idea is, well, instead of you getting it illegally, and instead of me giving you 90 Percocets to make sure you don't go into withdrawal, hey, you're going to come to this methadone clinic. I'm going to give you one pill a day. You got to come here. You got to do treatment. You got to take counseling. You got to drug screen, make sure you're not abusing other stuff. But if you follow the program, I'll give you one methadone to keep you out of withdrawal. It's like a risk aversion program. I don't want you prostituting. I don't want you sharing needles, spreading AIDS everywhere. I will help you, but you're probably going to be this for a long time. Okay. Other narratives, and I'll tell you about buprenorphine narratives. This is important because that's the whole model. The model is to decrease risk. Because when you're on Suboxone, guess what? You usually end up on it for a long time too, or maybe indefinitely for some patients. So why the heck would someone do all those bad things to get some opiates? Like, what's the driving factor to do that?
Well, opiates they obviously work on the pain receptor, so it eliminates their pain. And a lot of times patients' physical pain comes from psychological pain, and they're not actually treating the root of that pain, and so they just continue to hurt.
So what's the reason people want to avoid the withdrawal so much?
Withdrawals are awful. They're you sweat, your heart rate goes up, you can go into delirium tremens, you could die from that.
Pause. Delirium tremens is alcohol withdrawal, not opiate withdrawal.
Yeah, you're right.
2, you can't die from opiate withdrawal, but you can die from alcohol withdrawal. So I'll give you the sweating. What else is associated with opiate withdrawal?
Nausea.
Nausea.
Like GI issues, I guess.
What else?
You could get
I think their anxiety goes up.
Oh yeah, definitely. Give me as many as you can. You got 30 seconds. Go.
You can get like muscle aches and like pains. Muscle. Yeah, muscle aches, I guess.
10, 9, 8.
You can, I think you can get like insomnia, like sleeping issues.
All right, time. That's it. Okay, so you got some. All right. So if I go and start explaining withdrawal symptoms, you're like, oh yeah, oh yeah, oh yeah. You know more than these. Okay, I know you do. But the reason you don't know more is because you don't understand the concept. All right. So here's the concept. The intoxication of a substance of addiction is usually the opposite of the withdrawal, and the withdrawal is the opposite of intoxication. So if you can remember one side, you can remember the other side. See what I'm saying?
Mm-hmm.
So why do we prescribe opiates? What are we treating?
Pain.
Pain. So when I'm intoxicated, I get pain relief. All right. And if I give you strong enough opiates, I can give some considerable pain relief. All right. Therefore, when you withdraw, you're going to have some severe pain. That's why people hate the withdrawal of opiates. It's because they can't bear the pain that comes along. I mean, you're talking deep, unquenchable pain, like deep joint achy. You can't soothe it. And they're hurting so bad, they're like, I don't care. I'm going to break this finger off to get me some more opiates because I'm hurting. Okay? That makes sense?
Mm-hmm.
All right. What's another symptom of intoxication with opiates or when using?
Sleepiness.
Okay, it can be sedating. There's your insomnia. Or activation. I'll give them. So that can also be irritability.
Oh, okay.
Okay. What else can we do? What happens? So let me give you another tool. So remember I talked about learning in frameworks?
Mm-hmm.
This second thing I'm about to tell you right now will be worth the price of admission once again. Okay. This will help you remember stuff. So let me scroll up a little bit. So I did my residency at Morehouse in Atlanta. And I was the only psych resident on a medicine like service with like 100 like foreign doctors, Africans, Asians, the like Indian doctors, like the most academically like I was born to be a doctor type of person. Like they're expected to be doctors, and if you're just a doctor, you just barely made your smart level, right? Only psych resident in there. And one thing that intrigued me is how they developed their differential diagnosis because it was always like thorough. And we have a whole board full of stuff like, oh, I had a pinky toe pain, and I write a whole board for differential. And here's how they did it. They did it systems based. And it was like, oh, what are all the cardiovascular reasons that you could have this problem? What are all the respiratory reasons you can have this problem? What are all the GI reasons you can have this problem? What are the genital urinary reasons you can have this problem? What are the musculoskeletal reasons that you can have this problem? And so on and so on and so on. And they say, oh, it could be, circulation issue, and it could be this, it could be this, and this, and all of a sudden they got like 20, 30, 40 things. And I was like, how do I play that psychiatry?
Mm-hmm.
So you do the same thing in mental health. Okay, what are the mood reasons? And what are the anxiety reasons this person is experiencing life this way? And what is the psychotic reasons? What is substance use or substance abuse reason they can have this life presentation? And what are the childhood and developmental disorders that could explain why they are the way they are, and personality, and so on and so on.
Mm-hmm.
So if you drop things into categories, you will bring more information to your consciousness, because what happens is inside your brain you have millions and millions and millions of facts, and when I ask you a question, you're trying to search that whole database and you know where to look first.
Mm-hmm.
But if I just narrow it down to one file cabinet, you find it more easily. So when we're talking about symptoms of intoxication, you can do the same thing. All right, what are the cardiovascular effects of opiates? I'm thinking about it.
Decreases heart rate and blood pressure.
Mm-hmm.
Oh, you're getting it now. Excuse me, wrong way. Blood pressure. And then let's say, what about GI effects?
Constipation.
Oh, yeah. People get constipated. You have to prescribe medicines for those people on chronic opiates because they can't poop. Well, guess what? When you withdraw, you see how that works?
Uh-huh.
Oh, my goodness. And you can just kind of go through each body system, think about how opiates are affecting that body. So if you think about it, you have opiate receptors all throughout your body. So you can expect there's some type of symptomatology associated with each body system. For example, in the respiratory system, I'm going to get respiratory depression, so decreased respiratory rate. I don't know if I give you most opiates, the patients turn blue because they stop their respiratory drive. That's why they overdose. So guess what you get when you withdraw? You get tachypnea because it's the opposite. See how that works? All right, so we won't go through each symptom, but that'll help you with most substances. When you think about alcohol withdrawal, it's going to be the opposite of intoxication. All right. Now, some substances you don't necessarily get physiologically addicted to, so it may not work one-to-one for every substance. But if you look at cocaine, you'll see the same thing. That's why people have like a pseudo depression when they crash off of cocaine, because it's the upper, it's like it gives you like mania on cocaine, and when you withdraw from it, it's like you have depression. I see it all the time, back in the ER days. All right, so this is the driving force why people want to use opiates so much, and it's almost 12, okay? But I hope this is giving enough value that you want to hang out to kind of get this to the finish line, okay? All right, so now, since this is the problem we're trying to solve for the patient. I want you to avoid that so you don't do bad things. So I'm going to give you either a full agonist, so I can activate those receptors, or a partial agonist. So now we got to think about the receptors. And this is help you understand. This is kind of like what you came for when it comes to MAT and understanding it. So the way I think about it is this. This is my cell membrane. Let's just say these are my opiate receptors with the mu receptor on or whatever, right? And this is me at normal homeostasis. I don't take any drugs or anything like that. And then one day I get in a car accident. Doctor gives me 60 Percocets. My brain loves it, and I can't stop it. And now, every day, I'm going to take a bunch of opiates, and I'm going to get pain relief, and I'm also going to have sedation, and my heart rate's going down, my blood pressure's down, I'm hella constipated, and my respiratory rate goes down, and my body's like, wait a minute, we ain't in homeostasis. We like homeostasis. We don't like this. So how do we stop it? Because we can't get him to stop eating Percocets for breakfast. So next concept we need to understand is downregulation. So your body, in an attempt to stay in homeostasis, is going to say, you know what? Let's just not make so many receptors that this opiates can connect to so that I can keep breathing, because you just took 120 Percocets. So I downregulate my receptors. That makes sense? However, these receptors are supposed to be keeping you pain-free, because guess what? You stub your toe, and your clothes, you don't realize it, but your clothes is rubbing your skin, is damaging it, and this is a pain signal that's going out, but it's not that serious. I'm just getting a little bit of endorphins to make sure you're not constantly in pain from all the micro tears that happen in your body as you walk through your day. So these are supposed to be regulating your pain and other things, right? Now, all of a sudden, you take your 100 Percocets, whatever, you got plenty of agonists in the system that's ready to attach to these receptors. But I downregulate it, so only these two are going to attach to. So now I got to take more to get the same effect. That's tolerance. That makes sense? All right? So now I'm taking more of the substance to get the same effect. My body's like, what the F, man? Right? So now you're taking 200 Percocets a day. I know that's a very extreme answer, but people, you'll be surprised. People do it, right? Now all of a sudden, the person's cut off. And you don't have any opiates. And I done downregulate all my receptors that can control your pain and your gut motility and all your other stuff that happens. Boom, all of a sudden you have all those withdrawal side effects. That's why you have it. It's because you can't regulate your homeostasis because you downregulated your receptors so much. So if I wait long enough though, I need time, but I can make more receptors. That's why there's a window that people go through withdrawal. That makes sense. Like that's why in the movie say, "Oh, I'm gonna lock myself away in this cabin, away from society, and I won't have it. And I just gotta get through these X amount of days." Now, you know what's happening? Your body's doing protein synthesis. Oh, we gotta build more receptors. Oh God, we're dying over here. Let's make some more receptors, and then when you get enough receptors, everything's go back to homeostasis. You feel better.
That makes a lot of
Why don't
sense.
they teach it like that in school? I don't know, right? So that's the concept of down regulation and why you have withdrawal. That's the same for all the stuff with withdrawal. So let's use alcohol. Alcohol, you hit the GABA receptor. You drink. I make less GABA receptors, right? But also you got to understand there's up regulation too. All right. So GABA is the brake. Now we switched to alcohol now. Okay. GABA is the brake. I'm drinking every day. I make less GABA receptors, right? But guess what? You've been drinking so much, we almost unconscious, but we got to go to work.
I have a question.
Yes.
I don't think I understand why you're making less GABA receptors when you're drinking more alcohol.
Okay. Thank you for asking that question. All right. I'm a pilot. I got to fly you to California today, but I'm an alcoholic. Yep. You don't know that because I look hella normal. But before I got on this plane, I just drank a half a bottle of Jack Daniels. You wouldn't even know it. Okay. In fact, I'm lying. I drank a whole bottle of Jack Daniels. And you can't tell the difference. You know why? Because the mechanism of action of alcohol is to activate the GABA receptor. So now I got all my GABA receptors. They're doing their thing. They're, appropriately breaking my brain. So I'm not overly excited. Right? They're doing that appropriately. GABA's telling the brain to slow down. It's a break. But I'm also giving you an outside source that's telling you to slow down. Alcohol. Now I'm getting sleepy, stuporous, coma, because I'm turning on GABA throughout the brain as my alcohol level goes up. So my brain's like, I gotta fly this plane. I can't be stuporous. Let me down regulate these receptors. So even though you drank a bottle of Jack, you look like a regular person because I've down regulated these GABA receptors. But remember, we were about to talk about up regulation.
Oh, I see that.
Right.
You downgrade to stay for the homeostasis.
Right, stay in homeostasis. But guess what? I need you to stay awake and just down regulate my GABA receptors. Not quite enough because I'm gonna up regulate your glutamate receptors. I'll make the brain more excitable. Okay. But guess what? All of a sudden, you don't have any alcohol. Now I have excessive activation, too much glutamate, and I can't stop it because I don't have any GABA. That's why you have delirium tremors, you have seizures, you have all the stuff that come along with alcohol withdrawal. Is because understanding up regulation, down regulation. Same thing happens with opiates. Okay. All right. Now, here's how it all makes sense now. Now that you understand what the body's trying to do, I'm just trying to chill, man. I'm stay in my homeostasis. You keep messing it up. I got to upregulate and downregulate just to function throughout my day. So what the medicines do are taking advantage of those phenomena. So my 3 strategies is, hey, I can help you detox from this. It's gonna suck. I'm talking about opiates again. This is how we used to do it in the hospital. And people hated us for it. Because we know this is that opiate withdrawal is not life-threatening. It sucks, but it ain't life-threatening. So if you get admitted and you're addicted to opiates and you're at one of the hospitals around here, guess what? You ain't getting the opiates. You're gonna get supportive care. You pooping? I'm gonna give you anti-diarrheal. If you know the term cold turkey, I'm gonna quit cold turkey. You know where that comes from, right? That comes from opiate withdrawal because you get piloerection when you're withdrawing from opiates. So they look like a turkey, a cold turkey flesh. If you cold, the treatment for that is a blanket. If you sweating, the treatment for that is a towel. If you are snotting, I'm gonna give you a tissue. And so on and so on. If you're in pain, I'm gonna give you Tylenol. That ain't gonna really help, but at least we're doing something. And we just gonna wait it out. And you're gonna hate me for it, but you're gonna be detoxed when you're done. Okay. And meanwhile, you're going to upregulate those receptors and you're gonna start feeling normal. But guess what? I didn't fix your psychological addiction to it. So I gotta keep you safe because you're at high risk for overdose because you think you can still take them 120 Percocets. But now you've upregulated your opioid receptors. If you take them 120 Percocets, you're going to kill yourself. And that happens all the time. That makes sense? Makes sense why that happens, huh? All right, very good. So that may not always be the best course of action for patients if they're psychologically addicted to and they're in a lifestyle. So just getting detox is not enough for many patients. So my treatment options are, hey, I can put you in a methadone clinic and we're going to do what we said earlier. but you're probably going to, unfortunately, be a slave to this for a long time. And at your best, you may get 3 or 4 days that you can get, holiday medicine, but you're going to be coming to this clinic like every week, rest of your life. Okay. You may, and the thing is, as they try to taper people off of methadone, is very difficult. Methadone is a very long-acting, very powerful agonist of the opioid receptor. Okay. Patients sometimes can have a difficult time coming off of it. Okay. So you'll see patients on, I don't know, I'm making this 140 milligrams of methadone, and you try to bump down to 130, and they'll start feeling withdrawal symptoms. So they'd rather just stay at 140. You see what I'm saying? So it can be very difficult to get people off of methadone, and it's a cash cow for the clinics, just being honest. The reason I never started a methadone clinic, even though it was a cash cow, because I feel like ethically, like, it's hard for me to say that everybody's going to treat people ethically with methadone, because like you are coming every day and Medicare is going to pay every time you come, regardless. And I really just had to see you for like 5 seconds. Cash cow. And I'm going to make money off my P cups. All right, other option would be to give you buprenorphine, but I don't want to give you that by itself. I usually give it in combo with the naloxone. Here's the concept, and then here's how we apply it, and then we'll wrap it up because I'm kind of hungry. Okay. All right. So we talked about kind of the mechanism of action, agonist versus antagonist, but we also have to understand affinity for the receptor. We usually refer to that as a K value. I think it's inverse value. Okay. That says value, K value. Okay. So if something has a high affinity for a receptor, what that means is like when the substance, and if y'all can look at my visual, y'all need this, right? So if you think about when we give medications to a patient, no matter what medicine is, if it's receptor based, the medicine's going to bind to the receptor and it's going to disassociate from the receptor. It's going to bind to the receptor and it's going to disassociate the receptor. That's why we need to get blood levels so that the chemical is flowing in the blood consistently, so that as it flows by, it binds the receptor, let's go to the receptor. Binds the receptor, let's go to the receptor. Substances that bind the receptor irreversibly are called poisons. That's why you kill people with poisons, because it binds the receptor, making that receptor inoperative. It doesn't work anymore. And if you get enough cells, it can kill you. Okay. So drugs have different affinities. Some drugs have a low affinity. Other drugs have a very high affinity. That makes sense?
Yeah. High stickiness, low stickiness.
I like that. Okay. So the affinity of the medication makes a difference. So here's why I think Suboxone is one of our magic bullet type of medications in psychiatry. We don't have many things like it to solve a problem. So I have my little opioid receptor. My full agonists, say methadone, Vicodin, fentanyl, whatever it has, it's going to have affinity to the receptor, and it's going to bind this receptor. Okay, and it's going to fully turn it on. Okay, because it's a full agonist. Buprenorphine has a higher affinity than all the other agonists. So if I give you buprenorphine in the environment where you have a full agonist attached to that receptor, buprenorphine is going to come in and knock it off because it has a higher affinity. It's like, that's my girl. Oh, get out of here, punk. Right? So think of it that way. So buprenorphine will knock a full agonist off of the receptor. So what's going to happen when you knock that full agonist off? So if you were fully activating that receptor, you can't fully do that. So guess what? The patient's going to go into withdrawal. So if a patient comes into my office today and they just took a bunch of opiates, they look normal, they feel fine, they say, Doc, I want to get off these opiates. Can we start Suboxone? I want to do that. And I say, yeah, I haven't taken my course in 10 years. I don't remember how to do it. So I'm just going to prescribe you Suboxone today, and you go ahead and start taking it. They're going to hate me because they won't take that first Suboxone pill, and that Suboxone will get in there and kick on the opiates off the receptor. They're going to immediately go into withdrawal. Okay? So that's good and bad. Okay? Here's why it's good. It's good because it really lowers the street value of Suboxone. because the people who are abusing on the street understand that if I take Suboxone, I'm going to go into withdrawal. I don't want that. Okay, so it lowers the street value. Okay, it's bad because if you don't know what you're doing, you're going to make your patient sick because you're going to give them Suboxone wrong. Okay, so for when you start somebody on Suboxone, you have to do what's called an induction visit. And basically what you do is you have your intake visit, that's day one. You're going to find out what they're taking, how much they're taking, what's their patterns. And the key question is, how long can you go before you withdraw? Oh yeah, I can go about 8 hours and then I'll start feeling symptoms. Okay, cool. I'm going to make your appointment at this time. You need to stop taking, your opiates, 9 hours before you get here or 8 hours before you get here. Because you want the patient in moderate withdrawal before you can administer Suboxone. That way you won't kick them into withdrawal because those receptors aren't occupied as much. So I can add this Suboxone. It's going to partially activate the receptors. They'll start feeling normal. So here's what it really looks like. They'll come in and they're not happy with you because they don't feel good. You're going to give them what's called a COWS. A COWS is a standardized rating scale. I think it stands for Clinical Opiate Withdrawal Scale. And it's like objective scale. And you just say none, a little bit, medium, or a lot. And they'll say, is the patient sweating? Okay, no, 0. Do they have pain level? 0. And you get the score, and the lower the score, the less withdrawal they have. So basically, it'll say, oh, from 0 to this is mild withdrawal, or 0 is no withdrawal. From 1 to this is mild. From this number to this number is moderate. From this one and above is severe. You want to get them in the moderate window. So basically, you're going to sit there and do a COWS every 15 minutes until they're into the range that you need them to be in. And then you administer the medicine. And then you do COWS again until they're 0. So basically, you prescribe the Suboxone the first visit. Tell them, do not take it. You got to bring it to the office with you. All right? Come to the office, and you're going to estimate. I'm going to give you, 4 milligrams of 4-2, which is like 4 milligrams of buprenorphine, 2 milligrams of naloxone. Okay, I think that's the numbers. I think it's like 2-1, 4-2, something like that. 8-4, whatever. I can't remember exactly. So you'll give them one of those Suboxone films. You wait 10-15 minutes. You do the COWS again until it goes down to 0. And then when they're done, if you gave them 2 films, I know your dose is going to be 8-4, whatever it is. Okay, or 8-2. I can't remember exactly what it is. So when they leave, you'll know their dose, and you prescribe that dose, and they take that indefinitely. Okay, and you see them in a month. See them every month. Now, here's why this is the magic sauce that I think that it is. Okay, because of these concepts of affinity. The last concept, this is the concept I didn't tell you. That's also the third one, is bioavailability. So, buprenorphine has oral and what's the word? Is it enteral? I can't remember. Let's just say injected. I can't think of the word right now. So if you look at the bioavailability of these things, buprenorphine orally, it's almost 100% bioavailable. That means that what I put in, it's going to be floating around in your bloodstream. But if you inject it, if I inject it, it has a low bioavailability. I don't know the number. I'm going to just guess 10%. Why is that important? That means if I prescribe it to you and you take it as prescribed, it's going to go in and do its job because it's prescribed orally. If you're trying to be a knucklehead and you're going to take it and trying to boil it down or whatever you do to inject it, well, you're not going to get any of that agonist effect. You're not going to get no euphoria, no pain control. It's not going to work. Okay. However, naloxone, which is a full antagonist that's going to block the activity receptor, orally is very low bioavailability. And I don't know the number. Y'all can chat GPT it. It's low though. Okay. But when it's injected, it's like stupid high. What does that mean? So if you take it as prescribed, you won't have an antagonist on board. You won't go into withdrawal. But if you're going to be a knucklehead and you're going to inject it, it's 100% antagonism of all your receptors. You're going to go into withdrawal immediately, and you're going to hate yourself for doing it. People don't abuse Suboxone in that way. Okay. Magic bullet. Now, don't get me wrong, Suboxone has street value. The reason it has street value is because now they understand how Suboxone works. The drug dealers know. So if you don't want to go Vicodin for me and you don't want to be high all the time, I can sell you Suboxone. You're running up the streets. I'm not monitoring it appropriately. You can smoke your weed and drink your alcohol. You can do your cocaine and everything else, but at least you won't be withdrawn from opiates, so you can buy Suboxone from me. So it does still have street value. That's why when you have clinics and patients in the clinic, you don't get refills. You see them once a month. You draw screen them, based on their risk. Like I usually do mine once a month. If my patient has been stable and they haven't popped positive in a year, I might do it once every 2 months for their drug screens. So, that's kind of the understanding of it. So here's the three things to bring home to help you understand that whole course. Is that you understand that we have a few tools. We have a agonist, we have antagonist, we got partial agonists. We understand upregulation and downregulation of these opiate receptors, and that's why we have the pain. We understand that the intoxication and withdrawal opposite, and all that's coming from this phenomenon of tolerance because I'm downregulated, right? And I know that if I give you agonist, it's going to turn the receptors on. If I give you a partial agonist, it's going to partially turn on to keep you out of withdrawal. But I understand there's different bioavailabilities. I understand that if I give you buprenorphine in the context of a full agonist, it's going to put you in withdrawal. That's why there's a certain way that we do it. And hopefully the narrative stories that I told you kind of categorizing things will help you bring more to your memory. And that gives you understanding of how to apply Suboxone in a clinic and why we do what we do. So there's some more details to that we can add, like how do you leverage Vivitrol, which is an injectable naltrexone. I'll tell you about that real quick. So basically, one other strategy is once people are clean, to give them an injectable naltrexone that doesn't block receptors. It lowers their desire for opiates, and if they do use opiates, the receptors are occupied, so they don't accidentally overdose. So that's actually a really good tool for patients that have reached sobriety, is to put them on Vivitrol shot. Okay. We also use it in alcohol use disorder. We'll give them naltrexone. It lowers their desire to drink. Works very well. And then when you do drink, you don't get a pleasure response from it, because it blocks some the internal endorphins. So you don't get like that, such good, I'm finally relaxing from my drink. You don't get that anymore. Okay. It takes the pleasure out of it. Okay. All right. I think I talked enough. Y'all learned some stuff. Let's get some lunch, y'all. Any questions? Any questions?
No, this is really good. I really
Thank you so
appreciate it.
much.
All right. Perfect. Thank you.
Really good at